like autoimmune hepatitis, and we're going to talk about this also in this lecture. Genetic could be Wilson disease, hemochromatosis, and alpha-1 antitrypsin deficiency. Structural, like biliary atresia and choledochal cysts. And also drug-induced hepatitis due to paracetamol or isoniazid. We're going to focus in this lecture on hepatitis A, B, C, D, and E from the infectious and autoimmune hepatitis from the non-infectious. A retrospective cross-sectional study was conducted to investigate the profile of hepatitis A, B, and C in Kingdom of Saudi Arabia, and to determine which age group hepatitis viruses most commonly infect. Of hepatitis A, B, and C, hepatitis B was the most predominant type, accounting for 53% of the cases, followed by hepatitis C virus, 30% of the cases, and hepatitis A virus, 17% of the cases. Hepatitis E infection predominates in children from 5 to 14 years, hepatitis B virus in young adults from 15 to 45 years, and hepatitis C in older adults more than 45 years. Despite significant changes in the prevalence of viral hepatitis A, B, and C, it remains a major public health problem in Saudi Arabia. However, it showed a significant decline in the last 2 decades, and that could be attributed to the vaccination programs and the improved health facilities. In terms of clinical manifestations, they are classified into phases. In phase 1, in this phase, patients are usually asymptomatic. Although many patients have evidence of prior infection, like in the lab studies, there is a positive hepatitis serology. However, these patients don't recall being exposed to the virus because they were asymptomatic. In phase 2, now when symptoms do occur, the patient can first of all develop non-specific symptoms, things like nausea, vomiting, malaise, fatigue, and so on. Phase 3, also called the ecteric phase. Ecteric means jaundice. Patients will become jaundiced and start having dark urine from the presence of bilirubin in urine, and a pale-colored stool. Other signs you can see as a result of the inflammation of the liver, things like right upper quadrant pain and hepatomegaly. The last phase, which is the recovery phase, where symptoms and ecteric resolve, plus liver enzymes return to normal. That was a quick introduction about hepatitis. Now let's focus on the specific viruses. We'll go through the hepatitis viruses one at a time. Let's start with hepatitis A. Hepatitis A is a picornavirus. It's a single-stranded RNA. The incubation period is 1 to 2 weeks. So any patient who has signs and symptoms of acute infection, they will usually expose for about 1 to 2 weeks before the onset of symptoms. It's transmitted in a couple of ways. It can be transmitted through personal contact, for example, sexual contact, or sharing IV needles among patients who use IV drugs. It can be also transmitted through drinking contaminated water, and this is a common mean by which a patient becomes infected. And also by consumption of raw seafood that contains the virus. Because you can acquire hepatitis A virus infection from drinking contaminated water, infection with hepatitis A is more common in underdeveloped countries, where there is poor sanitation and patient can consume water that is contaminated. Keep in mind that hepatitis A is an acute disease only, no chronic infection from this virus, and it's self-limited. It doesn't require specific therapy. The diagnosis is made through antibody testing. In acute hepatitis infection, there will be anti-hepatitis A virus IgM. Plus, the patient has symptoms in the active infection, and that's the gold standard. In the prior disease, there will be anti-hepatitis A virus IgG. The treatment of hepatitis A, as we mentioned earlier, it's only supportive, no specific therapy needed, involves rest, hydration, and adequate nutrition. There is an inactivated hepatitis A vaccine available. Does anybody know when hepatitis A vaccine is given? Anyone?
Is it given at 18 months first dose and 2 years in the second dose? So it's a dual dose vaccine.
Excellent. Excellent. Thank you, Lanud. So 2 doses of the vaccine are given. First one at 18 months and the second at 2 years of age. The last thing about hepatitis A is that hepatitis A is the most common cause of acute viral hepatitis, and that's a common question. Then from hepatitis A, we're going to talk about hepatitis E next. Why next? Why hepatitis E next? Because its clinical features are very similar to hepatitis A virus. Hepatitis E is orthohepvirus. It's a single-stranded RNA. The incubation period is from 2 to 8 weeks, and hepatitis E is sort of famous for causing outbreaks worldwide in resources-limited areas. And the reason this can happen because the main mode of infection is from fecal contamination of water. So this can happen in resources-limited area, leading to an outbreak. Just like Hep A, Hep E causes a self-limited acute infection and no chronic infection from this virus. The diagnosis of Hep E infection is usually made through detecting IgM antibodies to the Hep E virus. And as an alternative, you can also detect Hep E virus RNA in serum or feces. Again, just like Hep A, usually no therapy is required. One special thing to know about hepatitis E virus is that a small percentage of patients who develop acute Hep E infection will go on to develop fulminant liver failure, which is an acute severe liver injury due to massive necrosis of hepatocytes. And for reasons that are unclear, this is more common in pregnant women who have Hep E virus infection during pregnancy. And when anyone develops fulminant liver failure from Hep E infection, there is a high mortality rate up to 20% of the cases. So remember, hepatitis E has a high mortality rate in pregnant women. So Hep A and Hep E generally cause acute infection only and no chronic disease. Now we're going to move on to other hepatitis viruses that are more commonly cause chronic infection. The first one is hepatitis B. It's a double-stranded RNA virus, and the incubation period is around 1 to 6 months. It can be transmitted in 3 ways: sexual contact, intravenously, patients who share needles for drug use, transfusion, or needle stick. And lastly, mothers who are infected with hepatitis B can pass the virus to their babies. This is especially true when the mothers develop acute disease in third trimester. And when this happens, it's very important to know that babies usually have minimal symptoms at time of birth, despite the high rate of viral replication in baby. And that's because the baby has an immature immune system. How this happens? By exposure to infected blood or other body fluids. Transplacental is rare. And also keep in mind that it's not transmitted by breastfeeding. It's safe to breastfeed. And because of this risk, hepatitis B is the only vaccination it's given at the time of birth. It's always given shortly after birth. That's because you want to protect the baby in the event that the mother developed the infection in the third trimester, but did not know it because she did not have symptoms. So, to prevent prenatal transmission of hepatitis B from mother to the baby, you give hepatitis B vaccine plus hepatitis B immunoglobulins as soon after delivery as possible. Usually they're given within 12 hours. Remember, this is very important, not only to prevent the infection, but also to reduce the probability of chronic infection. Hepatitis B vaccine is given in 3 doses, as we mentioned, at birth, and the second month and 6th month. Now, what will happen if you don't give the vaccine and immunoglobulins? Without prophylaxis, 90% risk of vertical transmission. However, after prophylaxis, less than 2% risk. So that's why it's very important to give them the prophylaxis because it's really significant. Also remember that the age at the time of infection is the primary determinant of risk of progressing to chronic infection. Up to 90% of prenatally of infants infected prenatally or in the first year of life will develop chronic hepatitis B virus. And the most common prenatal cause of chronic hepatitis is hepatitis B virus. What are the clinical manifestations? Most cases are asymptomatic or subclinical. There are a couple of extra hepatic manifestations of chronic hepatitis B infection. The first one is the vasculitis syndrome or polyarthritis nodosa. This syndrome can be very hard recognized clinically because the signs and symptoms involve lots of different organ systems, and many of them are non-specific. So the question will come as a patient with chronic Hep B infection who develop fever, fatigue, weight loss, neuropathy. They will complain of weakness, arthralgia, joint pain, skin lesions, and renal failure. Another extrahepatic is glomerular disease, and the most common is membranous nephropathy. In patients with chronic Hep B, there is a risk of progression to liver cirrhosis, hepatocellular carcinoma, hepatitis D co-infection, and we're going to talk about this, and acute liver failure. For treatment, for acute disease, it's supportive, and for chronic, multiple antiviral treatments, for example, pegylated interferon alpha or nucleotide analogs. Now we're going to talk about the diagnosis of Hep B, and that's super antibody that can be measured in the plasma. There are three antigens, the surface antigen, the E antigen, and the core antigen, and three antibodies, the surface antibody, the E antibody, and the core antibody. We're going to talk about them in a minute, but in general, I want you to know that antigens rise in acute disease and they fall as infection resolves. Antibodies, they rise as acute infection resolves. Let's start with the surface antigen. The hepatitis surface antigen is the hallmark of infection. It's detectable weeks after exposure, even before symptoms occur. And if the patient clears the infection, the virus will be undetectable after 4 to 6 months. Conversely, if the patient converts to be chronically infected, the hepatitis surface antigen will remain positive for more than 6 months. In patients who had a prior Hep B infection that they have cleared or they have been vaccinated, they will have the presence of the antibodies to the surface antigen, but they won't have the surface antigen itself. Look at the table. Patient with acute infection, they are positive for the surface antigen and they won't have the antibody. In contrast to a patient with a prior infection, that they have cleared or vaccinated, they will be positive for the antibodies, but they won't have the antigen present. Patients who are chronically infected, the surface antigen will be positive for more than 6 months. The hepatitis B vaccine contains recombinant hepatitis surface antigen. This basically means it contains the surface antigen proteins that is generated through a recombinant DNA technology in the lab. So vaccinated individuals will be positive for antibodies to the surface antigen, and all the other antibodies should be negative. Look at the table here. A prior vaccinated patient, the only positive test is the antibody to the surface antigen. All the other antibodies, including the antibodies to the core, we're going to talk about this in a minute, are going to be negative. Contrast that with a patient who has a prior Hep B infection. The patient will also have antibodies to the surface antigen, but in addition, the patient will have antibodies to the core antigen, which is not seen with a patient who's vaccinated because the patient have never been exposed to the core. There is no infection. So that's the core antigen. The core antigen is a viral capsid core protein expressed by infected hepatocytes. You cannot detect the antigen in the serum, but you can detect the antibodies. So in acute infection, IgM antibodies to the core will rise. And in patients with prior exposure or chronic infection, the IgG antibodies to the core will rise. So IgM in acute and IgG in prior exposure, prior infection or chronic infection. So once again, if we go back to the previous slide, patient who is vaccinated, they won't have antibodies to the core because the patient have never been exposed to the antigen. There is no infection. In contrast to the patient with the prior infection, they have antibodies to the core. Why IgG is positive in prior infection? Because we said IgG for prior infection and chronic infection. IgM for acute. Okay? The window period is a brief period during infection where levels of hepatitis surface antigen have begun to fall because the body is clearing the infection. And therefore, you cannot detect the surface antigen any longer. But the antibodies to the surface antigen are not yet detectable because their levels are still rising and relatively low. So during this period, you can get the false impression of no infection because there is no antigen and they won't be antibodies to the antigen. So the way you know you're in the window period is a sole marker of infection. It's the anti-hepatitis score IgM. As shown in the table, surface antigen, surface antibody, all negative, but you can detect the IgM antibody to the core. If you retest this person in a couple of weeks, the antibodies to the surface antigen will become positive. Two words about hepatitis E antigen. This is a viral protein secreted by infected cells, and when you're able to detect the E antigen in the plasma, this generally indicates a significant viral replication. So when E antigen is detectable, know that this patient is highly infectious. However, the hepatitis surface antigen, it indicates the presence of the virus. So either there is infection or not, but not necessarily significant replication. And that's a summary for the diagnosis of Hep B. Make sure you know everything in this table. This is very important. As I said earlier, if the hepatitis surface is positive, the patient is either acute or chronic, so there is infection. However, if the hepatitis surface antigen is negative, the patient is not infected. Let's review them again. In a prior vaccination, the only positive test is antibodies to the surface antigen. The rest will be negative. In a prior infection, also it's going to be positive for the antibodies to the surface antigen. In addition, the IgG antibodies to the core will be positive. IgG will rise in prior infection. In the window period, the surface antigen, the surface antibody will be negative. The only and the sole marker for window period is the IgM antibodies to the core. In acute infection, there is infection, so the surface antigen is positive. Plus, the IgM antibodies to the core will be positive since IgM rise in acute infection. And in a chronic infection, again, there is infections, so hepatitis surface antigen will be positive, in addition to the IgG antibodies to the core, because we said IgG will rise in a chronic infection and in a prior infection. I hope it's clear. Okay, so we're done from A, E, and B. Now let's talk about C. Hepatitis C from the flavivirus family, it's an RNA virus. The incubation period is 2 weeks to 6 months. Most patients with Hep C infection acquired through either intravenous drug use, or blood transfusion. Acute illness from hepatitis C is usually asymptomatic. Also, patients with chronic hepatitis C infection are usually asymptomatic with mild non-specific symptoms. You can make the diagnosis of hepatitis C by detecting the hepatitis C virus RNA by PCR. The level of RNA will be elevated soon after exposure. You can also test for antibodies to hepatitis C virus, and these antibodies become elevated by 12 weeks after exposure. Just like Hep B, Hep C infection is associated with liver cirrhosis, liver failure, and hepatocellular carcinoma. For treatment, hepatitis C infection is treated with a combination of two direct-acting antivirals. One last thing about hepatitis C is that all patients with chronic hepatitis C infection should be vaccinated against hepatitis A and hepatitis B. And that's because infection with one of these viruses on top of hepatitis C virus make the liver disease worse. The last virus is hepatitis D. It's also called defective RNA virus. Why defective? Because it doesn't have the genes to produce the envelope proteins it needs in order to replicate. Therefore, what it does to replicate, it requires hepatitis B surface antigen and uses that as its own envelope protein. So clinically, the only way you can get hepatitis D infection if you are already infected with Hep B. The incubation period is 1 to 6 months. And just like Hep B, chronic infection may lead to liver cirrhosis and liver failure. The treatment choice of hepatitis D is pegylated interferon alpha. And you should always be aware anytime you vaccinate patients against hepatitis B, you're also protecting them against hepatitis D because patients cannot acquire hepatitis D unless they first have Hep B infection. Last topic we're going to discuss today is autoimmune hepatitis. Briefly, it's a rare form of a chronic hepatitis that mainly affects women. The etiology is unclear. It's commonly associated with other autoimmune conditions. Clinical presentation varies, and patients may be asymptomatic or even show signs of acute liver failure. You can make the diagnosis by detecting serum antibodies. In type 1 autoimmune hepatitis, you can detect the anti-nuclear antibody and the anti-smooth muscle antibodies. In type 2 autoimmune hepatitis, which is most common in children, you can detect the anti-liver kidney microsomal 1 antibody and the anti-liver cytosolic antigen type 1 antibody. Liver biopsy should be performed following the serum antibodies to confirm the diagnosis. The biopsy alone is not diagnostic due to similar histological findings across many of the other causes of chronic hepatitis. Now, in the histology image, we can appreciate lymphocytic infiltrates, multiple dark blue dots, with apoptosis of the hepatocytes surrounding the portal tract. It can be seen in the center of the image, piecemeal necrosis marked by the arrowhead. Inflammatory infiltrate at the interface of the portal tract and the hepatic lobule is known as interface hepatitis, and it's a characteristic feature of chronic hepatitis. For treatment, immunosuppressive medications such as prednisone with or without azathioprine. Many patients require a lifelong immunosuppressive therapy, but some may be able to stop medications after several years under careful monitoring for recurrence. I'll conclude my lecture with this summary. Hepatitis A and E cause acute hepatitis. Hepatitis B is the only subtype that is a DNA virus. Hepatitis B and C usually progress to chronic hepatitis in children. Hepatitis A and B are the only subtypes with available worldwide accepted vaccines. The younger the age of the patient infected with hepatitis B and C, the higher the chance of progression to chronic hepatitis. That's a summary for you guys, and thank you so much everyone for listening. If you have any questions, I'm more than welcome to answer before we go to the practice questions.
Thank you, Bina, for this wonderful lecture. Any question to your friend? Any question for your colleagues regarding hepatitis in children?
Everything's clear, doctor. Thank you. Thank you, Bana.
You can proceed with your question, Bina.
Okay, shall we go to the questions? Who'd like to go first?
I can do the first one.
Sure.
Okay. What do you give to prevent perinatal transmission of hepatitis B from mother to baby? A. Give baby hepatitis B vaccine and IVIG within 12 hours from birth. B. Give baby IVIG followed by vaccine after 3 weeks. C. Give baby only hepatitis B vaccine. And D. No need to administer anything. I'll go with A.
Excellent. Give baby hepatitis B vaccine and IV immunoglobulins within 12 hours from birth. Excellent. Thank you. Who'd like to read the second question?
I will read.
Sure.
A patient acquired hepatitis B infection 3 years ago and was cured. What do you expect his titer to be? I think C.
Excellent. So that's a prior infection. And antibodies to the surface antigen will be positive, and IgG antibodies to the core will be positive. Thank you so much. That's it. Thank you so much again for listening, and have a nice day.
يعطيك العافية. Thank you very much.
شكرا.
Now we will go with your colleagues, Ahmed, to give the second lecture, inflammatory bowel disease. Did you share your slide and you can start, please?
Yes, okay. Can you hear me?
Yes, we can hear you.
Yes, yes.
Okay. Can you see my slides? Can
Yes, we
everyone
can
see?
hear.
Okay, so Assalamu alaikum. My name is Ahmed Aerosmith. I'll be presenting.
Enlarge your slide, please. Just make it full screen.
Okay. Okay, is this clear?
Okay. Yes.
Okay, Assalamu alaikum. My name is Ahmed Aerosmith. I'll be presenting inflammatory bowel disease. So let's get started. Okay, so the outline of my lecture will be based on the epidemiology, etiology, pathophysiology, clinical features, and evaluation and treatment of IBD, the prognosis of IBD. So let's get started with the definition of inflammatory bowel disease. So inflammatory bowel disease, aka IBD, is just a term used to describe conditions that are characterized by chronic inflammation of the GI tract. So IBD is traditionally recognized as two disorders: ulcerative colitis and Crohn's disease, also known as Crohn disease nowadays. So in the epidemiology, the number of individuals affected by IBD across the globe recently in recent studies is recognized to be 6.8 million, and the prevalence is on the rise. And the peak incidence is 15 to 35 years old in both in IBD. And ulcerative colitis tends to have a slightly higher prevalence in males than females. Patients with higher prevalence include Ashkenazi Jews and individuals of Northern European descent. Crohn's disease is typically more common in pediatric patients. So recently studies show that up to 25% of patients with IBD have an affected first-degree relative, so genetic predisposition is extremely important and a key point in this disease. Now we'll talk about Crohn's disease first and its etiology. So Crohn's disease, first and foremost, is an IBD that causes inflammation in the bowel. Unlike ulcerative colitis, it could cause inflammation and tissue destruction anywhere along the GI tract. So the risk factors include familial aggregation, genetic predisposition, and the frameshift mutations in NOD2 and CARD15. And smoking is a risk factor for Crohn's disease, unlike in ulcerative colitis, where it is actually a protective factor. So it's generally caused by immune dysregulation and dysbiosis, which causes and enables chronic inflammation. So in the pathophysiology of Crohn's disease, an autoimmune it's generally not recognized as an autoimmune disorder because it's recognized as an immune-related disorder. An autoimmune disorder would be ulcerative colitis, where it's triggered by cells, but immune is mostly triggered by foreign pathogens. So yes, as I said, although ulcerative colitis is classified and treated as an autoimmune disease, CD isn't really an autoimmune disease. It's an immune-related disorder. The common implicated organism that could trigger an immune-related response in Crohn's disease would be Mycobacterium paratuberculosis, Pseudomonas, and Listeria. So a pathogen is first thought to activate the immune system. Then Th1 cells release cytokines, interferon gamma, and tumor necrosis factor alpha, which further stimulate the inflammatory response. This all leads to unregulated inflammation, then tissue destruction. So unlike in ulcerative colitis, in which the damage goes to the mucosa, in Crohn's disease, the damage is beyond the submucosa also, so we refer to that as a transmural inflammation. So in Crohn's disease, we have areas of healthy tissue which are dispersed, but it most commonly affects the ileum and colon. So like I said, there's a transmural inflammation, a non-caseating granuloma, giant cells, and distinct lymphoid aggregates of the lamina propria, which further aggregate the inflammation and cause a transmural inflammation. And healthy tissue is destroyed, which causes ulcers and creeping fat and hypertrophic lymph nodes. So the clinical features of Crohn's disease, a very common clinical feature is right lower quadrant pain, which probably refers to the ileum, because it's the most common site to be affected in Crohn's disease. We have diarrhea and blood in the stool, and if the small intestine is affected, then there could be malabsorption syndromes. An important distinction between an important point between Crohn's disease and ulcerative colitis would be the bleeding and the right lower quadrant pain, and the chronic diarrhea associated with Crohn's disease. So it most commonly affects the terminal ileum in children, and it can involve any part of the GI. So extraintestinal symptoms include enteropathic arthritis, uveitis, cholelithiasis, urolithiasis, and erythema nodosum and pyoderma gangrenosum. The extraintestinal symptoms are more common in Crohn's disease than they are in ulcerative colitis. So the complications of Crohn's disease include a fistula, abscess formation, stenosis, strictures, and intestinal perforation. So in the evaluation of Crohn's disease, we could do blood tests like CBC and ESR and C-reactive proteins and albumin levels. For stool tests, we could do a fecal occult blood test and fecal calprotectin. As for the radiological investigations, with a CT enterography and MRI enterography or bowel ultrasound, colonoscopy and upper GI endoscopy for endoscopic investigations, and of course histopathology. So the cobblestone appearance is typically because the areas of healthy tissue in Crohn's disease are dispersed, but mostly, as we said, the area of that is mostly affected is the ileum and the colon. Okay, so moving on to ulcerative colitis. So colitis refers to inflammation of the large intestine. So in this disease, there will be also ulcers along the inner surface or lumen, or the inner cells lining the lumen in the large intestine. It includes both the colon and the rectum, and sometimes we have in ulcerative colitis flares, which indicate new damage, and remission phases, which indicate healing. So actually, ulcerative colitis is actually the most common type of inflammatory bowel disease. Not that there's a lot, but it affects the mucosa and submucosa of the large intestine only. So as we said, the risk factors include HLA B27 association and a genetic predisposition, so a positive family history of IBD and history of intestinal infections is a big risk factor for ulcerative colitis. So unlike in Crohn's disease, tobacco smoking is actually protective for ulcerative colitis. So in the pathophysiology of ulcerative colitis, diet and stress were once thought to be the leading factors in the pathogenesis, but they're now thought to be secondary, and the disease is thought to be mostly autoimmune. Cytotoxic T cells would be found destroying the lumen cell lining, but it's unclear what they're targeting, and some patients have been found to have the ANCAs, which are thought to be the main target of cytotoxic T cells. These are mostly theories, but this is what we recognize, that there are early stages of the disease in which we have inflamed erythematous edematous mucosa, a friable mucosa with bleeding on contact with endoscope, and a fibrin covered ulcers and small mucosal ulcerations and a loss of superficial vasculature. In the chronic stages of the disease, we have loss of mucosal folds, loss of haustra, strictures, deep ulcerations, and pseudopolyps. So ulcerative colitis is more common